Thank you, Zara. It's always good at these kind of conferences to feel that you're in an inclusive environment, and I was very grateful to Lizzie this morning for that, because I realized that I was among my people, that I have eyes that now have a menu of options that you can choose. So my apologies for the paper notes. So I'm really grateful to MMI for the opportunity to present some of the initial work from my PhD at the Suicidal Behaviour Research Lab at Glasgow. And my studies there are funded by the Zoetis Foundation. As Zara mentioned, I've been looking at risk and protective factors for suicide in veterinary professionals, and that includes veterinary nurses, veterinary technicians as we step outside the UK, and veterinary students and students of veterinary technicians and nursing students. Before we begin, it is really important to acknowledge the nature of today's talk. I'm going to be talking about suicide. I'm going to be talking about suicide risk. I'm going to be talking briefly in one slide about suicide methods. And these are really challenging topics, and they can feel quite personal. And for some of us, they may well bring up difficult thoughts or feelings. So can I just encourage you, as one or two of our other speakers have done, you will be fully respected and understood if you look after yourself. If that means stepping out, if that means asking for support or help, then please do. I'm hoping that the research I'm going to present will be helpful for our professions, but it's equally important that we look after ourselves and look after each other. So, what do we know? Well, we believe that veterinary surgeons are 3 to 4 times more at risk of suicide than those in the general population. But we know that much of the data that we have is out of date. For example, the last systematic review in the UK was nearly 20 years ago. We're aware, and work on this systematic review has confirmed that a rigorous approach to research in this area is sometimes lacking, and work on suicide risk for others outside of the veterinary community, so veterinary nurses, veterinary technicians, veterinary students, is very much lacking. And our work here is not just about bringing numbers and graphs up to date. If we want to better understand risk, if we want to focus on protective factors for people, if we want to reduce the number of deaths by suicide, if we want to be able to meet people in crisis with useful interventions, then we need clear, evidence-based information. So for this systematic review, we had 2 clear research questions, and we focused on the prevalence of suicidal thinking and behavior, and also on the psychosocial risks and protective factors. And we had a clear focus on veterinary professionals from the groups that I mentioned earlier. The review was pre-registered on Prospero, and we employed database searches using 6 academic databases, and screening was supported by inter-rater checks from other members of the team. As highlighted previously, the most recent systematic review was by Platt and colleagues in 2008, and so we used that as a start point for our data searches. And we sought to build up peer-reviewed articles with a clear focus on veterinary professionals and suicide, where articles considered risk factors or protective factors, we sought to include those as well. The searches delivered over 1,000 records, and through screening, we ended up with a total of 54 papers for the systematic review. And we employed 2 quality assessment tools, using one by O'Connor and colleagues for all of the quantitative papers and following Bennett and colleagues for the few qualitative papers. As you can see, we ended up with an average quality assessment score for the 40 quantitative papers, or sorry, the 50 quantitative papers, of just over 5, so a quality of low to medium, and only 4 papers out of the 54 were scored as good quality. The majority of the studies were cross-sectional. Just over 50% of them were from the US and the UK. And there were 14 retrospective studies which focused on suicide deaths, so either using national statistical databases or coroner's details. You'll be aware that cross-sectional studies just give you a snapshot of what's going on. So if I was hoping to be able to look at connections and causal factors, then my one lonely Australian longitudinal study was going to have to do a lot of heavy lifting. This is a summary of the 14 retrospective papers. I think it's really important to pause at this point. We can focus in a conference like this on numbers, measures, graphs, metrics, but we need to see 670 people that we have lost to suicide in our professions. Families, colleagues, friends, absolutely devastated. Many of us in this room, I suspect, will share some of that lived experience. And in the midst of all that we're trying to do to analyze and develop and support work within suicide prevention, we must never lose sight of that. Now, before I move on, there's a phrase I need to apologize for. We need to talk about statistics. The 14 studies describe suicide death and suicide risk using 5 different metrics. This one slide could, in all honesty, be a very boring 15-minute talk. If there's anyone in the room who'd like to discuss it further, please come and find me at afternoon tea. But for everyone else, I just really wanted to make the point that the diversity of metrics that's used makes analysis of data really quite difficult. So this is a summary table. It shows 13 of the 14 retrospective studies. One US data set was used twice. And I hope the first thing that strikes you is the gray blank boxes where we don't have any usable data. And maybe the second thing, the column on the right, even when we do have usable data, it is often not good enough, or there are reasons that we cannot use it to draw conclusions about significance. In this presentation, I can obviously only briefly look at some of the challenges. We're dealing with small numbers. Take the UK, for example. 69 million population, I think, or thereabouts. There are 60,000 veterinary surgeons and veterinary nurses in the UK. So very small numbers. And that means that even with increased risk, a death by suicide still remains a very low frequency event. The studies, as you can see, report a range of metrics. And they also make comparisons to very different populations. Risk versus clerics or psychologists in Norway, risks versus the whole population of the USA. Data reporting in these studies is understandably quite often constrained by privacy. Many national databases will put a limit on the number of cases you have to have before you can actually use the data. And also, they find that coroner's verdicts in these kind of cases are often very variable. One Australian study found cases which they considered suicide, but where the coroners had stated them as death by misadventure or death through the misuse of drugs. One Austrian study returned the result that 10% of 200 veterinary deaths had an unknown cause. I hope you'll have begun to appreciate that interpretation of data of this type is not really that straightforward. However, analysis of the prevalence data does continue to support the conclusion that suicide mortality remains significantly higher in our professions than in the general population or indeed among other similar professions. It looks from this data that vet suicide risk is perhaps 2 to 3 times that of the general population. But we'll all be aware that there's been a very significant and global reshaping of demographics within the profession. 50 years ago, 95% of the veterinary profession was male. Currently, if we think globally, over 60% of clinical vets in the world are female. Over 75% of vet student cohorts are female, and those figures for vet students are higher in the UK. 97% of our RVNs and students are female. And it appears from this data that female vets in particular, because that's mainly the people that are there to study, have a disproportionately higher risk of suicide. And that is often much greater than women in the general population. And also it stands against the general suicide statistics, where normally we would expect that men would have a 2 to 2.5 times higher risk. At the same time, and it's very easy to pass over it as a single sentence, there are whole sections of our veterinary teams that have not even really been considered, or we don't know what's happening. The prevalence data also raises very significant questions around practical capability for suicide and access to means. Veterinary teams have frequent access to dangerous drugs and indeed to firearms. They are skilled and experienced in their use. 80% of veterinary suicides in Australia between 2001 and 2012 were by self-poisoning. And in almost every case, the drugs used were diverted from the practice. And we've looked at data in Austria, where 64% of vet suicides were by self-poisoning. Over the same time period in the general population, the figure was 15%. Suicide attempts are frequently impulsive, but there is compelling evidence that the most intrusive suicidal thoughts are often short-lived, and when a lethal method is less available, people are more likely to survive in a crisis. It's also worth noting, rather shockingly, in one American study, that only 13% of vets who died by suicide had a previous suicide attempt. Suicide is always complex, and we don't seek to oversimplify, but it's clear that access to means alongside the practical capability is a real problem in our vulnerable populations, where people have access to a means of suicide with very high lethality. Rosie Allister and colleagues are just in the process of concluding a study looking specifically at the situation and the risks around access to means, and they hope to be able to bring more clarity to this whole area. Following on to the cross-sectional studies, well, if the retrospective studies had plenty of heterogeneity in their measures, it went to a whole new level, as you can see. 40 cross-sectional studies, 29 different psychological measures, 70 questions where they were either just individual questions or had been adapted or changed by the people leading the study. It's a huge level of heterogeneity. And there's a real noticeable lack of standardized outcomes, longitudinal designs, as I mentioned, and consistent sampling methods. And then when on top of that, you add in all the other bits and pieces from studies, you know, the difference in populations, what are people's career stages, what's the region that the study was done in, what's the gender balance, given that we're talking about the feminization of the profession. Things like the study method. Was it an email to a mailing list? Was it something that was handed around students in a particular year at one university? We know that studies like this, looking at mental ill health, distress, suicide, can sometimes also see some self-selection from people who are in distress. And then perhaps one of the more important things, that even where studies used the same clinical measures, they often chose different cutoffs and different thresholds. So clinical significance, high distress would be different for the same measure between two different studies. It's difficult as an early careers researcher to stand here and criticize, but the systematic review has very much thrown up that we need more evidence-based results and less anecdote. Across the multiple cross-sectional studies, rates of suicidal thinking and suicide risk are consistently elevated, and they're often substantially elevated above those in the comparison populations. So these findings highlight there's a real disparity in mental health outcomes for the groups in these populations. Suicide risk appears to be shaped by a very complex interplay of occupational stressors, personal vulnerabilities, contextual pressures, limited support in the workplace, high workplace demand, little control over your work, and experiences of burnout or low reward in your work are often thrown up as some of the things which will amplify the risk. Prior mental health difficulties, substance misuse, including alcohol, as we were talking about earlier, and lack of social support outside of work can also contribute. And then we also need to think about exposure to things like challenging client situations. All of these things can exacerbate psychological strain. Although fewer in number, some studies do consider protective factors. Strong colleague and peer groups, a sense of autonomy in your job, effective coping strategies, and also a willingness to ask for help. And if you're a woman in the audience, you're at least twice as likely to do that as my male colleagues. All of those things can help protect against pressures. I'm afraid in the time that we've got today, I can only really scratch the surface. But I believe the papers in this review underscore the reality that much of the psychosocial risk that those in our professions face will not be solved by focusing on the individual. We're currently proceeding with further work to explore risk and protective factors, and in particular to look at the transition from suicidal thinking to suicidal behavior. It's been really humbling to see the way the profession has responded, and absolutely fantastic to have good numbers of RVNs and students taking part. If you'd like any information on any of the references that I'm referring to in this report, please do come and speak to me. I'd like to finish by coming back to where I started. These are unavoidably hard topics, and it's okay to find them uncomfortable. But if they have brought up difficult thoughts or feelings for you, I would encourage you to please reach out and talk to someone that you trust, or indeed to talk to VetLife confidentially 24/7. Thanks for your attention, and I'd welcome any questions.